Hello, this is Tobias Carling here from the Carling Adrenal Center and the Hospital for Endocrine Surgery here in Tampa, Florida. So we're doing a question and answer session. As you know, the Carling Adrenal Center is the premier worldwide destination center for patients with adrenal tumors and patients that need adrenal surgery. And we got some excellent questions sent in to us, and frankly, many questions are quite sophisticated. So you have to put on your thinking caps and really think, because a lot of these questions, frankly, very few medical doctors would know how to answer and really understand the questions. So you got to put your thinking caps on and listen carefully, because there's some very important questions, but some are quite sophisticated in their nature. So we're just gonna give one moment to let people log in, and we'll get right to it. All right, so we'll start off. So the first question is, can you please speak about the tests that need to be done by your primary care doctor or endocrinologist to diagnose adrenal diseases? Well, so what tests should the doctor perform? It depends a little bit in what context. Is it because you have an adrenal incidentaloma that needs to be ruled out for hormonal overproduction, or if a patient presents with specific symptoms, for instance, specific symptoms of Cushing's syndrome or specific symptoms of pheochromocytoma. But it's helpful to think of it about cortisol, aldosterone, and adrenaline type tumors. So you have Con syndrome, Cushing syndrome, and pheochromocytoma. So the tests that needs to be done is to rule in or rule out one of those diseases. So when it comes to testing for aldosterone producing tumors, the two major tests are a plasma aldosterone concentration, that's a simple blood test, as well as a renin. And actually the renin is the most important, because if that's suppressed, meaning low, that almost always prove an aldosterone producing tumor. When it comes to the testing for Cushing's, there's more than 10 different tests to test for cortisol, but the three most important ones are ACTH, low dose dexamethasone suppression test, and DHEAS. So the ACTH is a hormone produced by the pituitary. It's a simple blood test, but if that's low, that indicates that the cortisol overproduction is coming from the adrenal. If that's high, it could be a pituitary tumor overproducing ACTH. So the ACTH is important. The low dose dexamethasone suppression test, that's a test where you take a pill of dexamethasone in the evening and then measure your cortisol level. So if that cortisol level is still high in the morning after the pill, that proves too much cortisol. And the third one is the DHEAS. That's a precursor hormone in the steroid synthesis. So if that level is low, that indicates overproduction of cortisol. The DHEAS, though, can also be very high in adrenal cancer. That's rare, but that's an important test. So for cortisol, at the minimum, you want to check ACTH, low dose dexamethasone suppression test, and the DHEAS. Some endocrinologists will also check your salivary cortisol as well as a 24-hour urine-free cortisol. It's important to know about those tests. Those tests are only elevated in very severe Cushing syndrome. So if you have normal salivary cortisol or normal 24-hour urine-free cortisol, that doesn't rule out overproduction of cortisol. It just means that you don't have severe hypercortisolemia or severe Cushing's syndrome. Then when it comes to testing for a pheochromocytoma, that's metanephrine or catecholamines. That can be measured either in the urine, 24-hour urine-free cortisol, 24-hour urine-free metanephrine and catecholamines, as well as can be checked in your plasma as well. So again, to think of it, you want to rule in or rule out cortisol, aldosterone, and adrenaline type hormones. So the next question is, can someone have Cushing syndrome and pheochromocytoma at the same time? Yes, but that's very, very rare. So it's rare to have both Cushing syndrome and pheochromocytoma, but it can happen in two different scenarios. This is rare, but can happen. One scenario is you have two adrenal glands, right? So you have a pheochromocytoma on one side and a cortisol-producing tumor on the other side. Rare, but we've had a few patients that had that scenario, not necessarily at the same time, but first they had a pheochromocytoma, and then 10 years later they developed a cortisol-producing tumor on the other side. The other scenario is that occasionally a pheochromocytoma can, in addition to adrenaline-producing hormones, overproduce ACTH. Yes, I know this will blow your mind, but actually pheochromocytoma can overproduce ACTH. So that causes Cushing syndrome due to what we call ectopic ACTH. That's very, very rare, usually case reports being written in the literature. But yes, Cushing syndrome and pheochromocytoma can occur in the same patient, but it's very, very rare. Next question is, I have a left incidental adenoma, adrenal adenoma, incidentaloma, measuring 3 centimeters with no symptoms. What should I do? Is it still necessary to seek surgery even if it's not bothering me? Okay, this is a great question. So 3 centimeter tumor on the left adrenal gland, the patient doesn't have any overt symptoms. So number one, it's very important to know that about 50% of pheochromocytomas, for instance, are completely asymptomatic. And many patients with cortisol-producing tumors can have minimal symptoms, meaning they're minimally symptomatic, and it's only once you're probing that they know that they have symptoms. And sometimes aldosterone-producing tumors can be minimally symptomatic or asymptomatic as well. So even though that you don't feel bad or have any overt symptoms doesn't mean that the tumor is not overproducing hormones. You can have silent tumors that overproduce hormone, doesn't cause any symptoms, but they cause a lot of damage, including causing risks of strokes, heart attacks, and other cardiovascular abnormalities. So even though you don't have any symptoms, you do need to have your cortisol, aldosterone, catecholamines checked. So assuming that those are normal, let's say it's a non-functional tumor. Still, if the tumor has what we call an atypical imaging phenotype or an indeterminate imaging phenotype. So again, the tumor doesn't produce any symptoms, but if it looks funky, concerning on the scan, meaning it's indeterminate or atypical, sometimes those tumors need to be removed anyway because of the risk of cancer. So obviously, most cancers are enlarged, often more than 4 centimeters, but often 6, 8, 10 centimeters. But all adrenal cancers at one point were small to begin with, including being 3 centimeters. So if it looks concerning on a scan, sometimes we have to remove those tumors just to prove that they're not cancers. So again, it depends. Just because you have an adrenal incidentaloma doesn't necessarily mean that you need surgery, but you certainly need to have it ruled out for any hormone overproduction, and you need to have a sophisticated doctor looking at your scan to determine whether there's a concern about cancer. Next question is also a great question, and it's been a lot of research in this field that's important, which I'm going to mention. So the question is bilateral hyperplasia the same as bilateral hyperaldosteronism? So the easy question is yes and no, and I'll explain that. So, and I'm gonna get a little bit technical here, but bilateral hyperplasia is a pathological diagnosis. Bilateral hyperaldosteronism is a clinical diagnosis. So when the pathologists look at the specimen and the slides, they're just describing what they're seeing, what it looks like. They do have information on what kind of hormones the adrenal gland produces, and sometimes we stain, meaning look for protein expression of those hormones within the tumor. But the pathologists just describe what it looks like. And simply put, they just describing whether it's hyperplastic, whether it's micronodular, whether it's a tumor, and whether that tumor is cancerous. Bilateral hyperaldosteronism factors in what the pathology shows as well as what the clinical diagnosis is, meaning what type of hormone overproduction occurs. So in patients that have bilateral hyperaldosteronism, that means they have overproduction of aldosterone from both adrenal glands. Often when you look at those adrenal glands under the microscope, it will show bilateral hyperplasia. But it's even more complicated than that, because in the past we used to think of aldosterone producing lesions as either one of two things. You have a single adenoma that occurs on just one adrenal gland, or you have hyperplasia on both adrenal glands and they're overproducing aldosterone, meaning they're hyperplastic. In real life, it's not that simple, meaning you have a continuum of that. So you have just bilateral hyperplasia, but you can have bilateral hyperplasia with micronodules within the hyperplasia. You can have bilateral hyperplasia with macronodules, and you can have multiple adenomas or a single adenoma. So it's a continuum. And in fact, the more we study about these aldosterone-producing tumors, it's not uncommon that you can have areas of aldosterone overproduction that doesn't necessarily correspond to the biggest lesion, or you can have it in multiple lesions. So it's not as simple as just thinking about hyperplasia versus adenoma. It's a continuum. And this is important because what we're learning more and more, the classic teaching is we only offer surgery for patients that have a single adenoma, either by CT scan or adrenal vein sampling. But nowadays what we're learning, and a lot of this data is international data coming out of Japan, Australia, and Europe, showing that compared to just treating with one medication after another, even in the setting of bilateral hyperaldosteronism, it's probably better to offer either unilateral surgery or surgery on one side and a partial resection on another side. This is relatively novel. This is just in the last 18 months or so that this has been propagated, and it's really nobody in the United States that have significant experience with this, but this data is coming out of international groups where they're a lot more aggressive offering surgery to this type of patient. So that's a long answer to, on the surface, a simple question, but for patients with bilateral hyperaldosteronism, surgery is sometimes possible and even preferable over just one medication after another in perpetuity. All right, great question. So next question is, if I have my left adrenal gland out, will this affect my fitness level? I'm a competitive athlete. Also, will this affect my sex life and overall energy levels in a negative way? So the simple question is no. It won't affect either your fitness level or your sex life or your quality of life. So you have two adrenal glands. It's been shown in study after study that you only need 30 to 50% of one gland, meaning, simply put, you need half of one adrenal gland. So removing just one gland it's not going to affect your athletic capabilities. In fact, we operate on professional athletes all the time. We just had a young gentleman who's trying to make it to the Paris Olympics. He already was in the Rio Olympics and the Tokyo Olympics. So we have Olympic level athletes having adrenal surgery, and they do fine having just one adrenal gland. It's true if you had more than 1.5 adrenal glands removed, yes, then you could have a problem with your fitness level, and you could have a problem with your sex life and energy levels and so forth. But as long as you have at least half of one adrenal gland, you will do fine. Next question is, approximately how much time will it take for the body to heal after the mini-back scope adrenalectomy to get back to normal activities? Yeah, remarkably quick. And much more quicker than any other surgery. If you do a surgery going through the belly where you violate the abdominal cavity, it can take weeks to months to recover. Going through the back and staying in the retroperitoneum, which is the beauty of the mini-back scope adrenalectomy, means that the patient recovers much faster. And also the recovery is related to the time of surgery. Fortunately, since we do this all the time, we can do this in a very efficient manner. So the shorter anesthesia time, meaning minutes instead of hours, is beneficial for the recovery of the patients. But already the same day of the operation, the patient is up walking, can take a shower, walk in the hallways. For people that we recommend that people don't do any heavy lifting for 2 weeks, meaning greater than 20 pounds. For people that exercise a lot, they can go back walking on a treadmill, an elliptical, pretty much within days after surgery. But especially core exercises that involves the abdominal muscles, we want patients to wait at least 2 weeks and then slowly get back to those exercises. And obviously listen to your body. If you have pain when you're exercising, you should slow down. All right, so this question relates to the cardiac abnormalities or the cardiac manifestations of the disease. So as you know, cortisol, aldosterone, and adrenaline, all of those hormones are very bad for your vessels and very bad for your heart and your brain. So the question is, I developed atrial fibrillation, AFib for short, as a result of a tumor on my right adrenal gland. Will the AFib correct itself after removal of the adenoma? So atrial fibrillation, so you have 4 chambers in your heart. You have the 2 ventricles and you have the 2 atria or the atrium. So when you have atrial fibrillation, that means you have the atrium of the heart is beating faster than the rest of the heart. That's what AFib is, or atrial fibrillation. And all adrenal hormones increases the patient's risk of developing atrial fibrillation, which is the arrhythmia of the heart, especially aldosterone-producing tumors. So patients with Conn's syndrome, primary hyperaldosteronism, do develop atrial fibrillation. But also patients with pheochromocytoma and Cushing syndrome can develop AFib as well. So they increase the risk of the AFib developing, and AFib can sort of come and go, or it can become chronic. And usually when it's become chronic, it requires either a cardioversion or a heart ablation for the heart to go back into what we call normal sinus rhythm. That's the way the heart is supposed to beat, all synchronized and together. So removing the adrenal tumor and normalizing the hormones will not necessarily make a patient who's already in atrial fibrillation go back into normal sinus rhythm. But what often the cardiologists do is then after the adrenal tumor has been removed, they may put you on medications or do a procedure to get you into normal sinus rhythm. Because once the adrenal tumor is removed, the cause of the AFib is removed and your propensity to develop AFib again will go down. So you definitely want to have that adrenal tumor removed if it's overproducing some of those hormones. But in this scenario, we'll often coordinate the care with a cardiologist, and sometimes the atrial fibrillation has to be addressed before we do the adrenal surgery or vice versa. Can all adrenal tumors cause symptoms such as weight gain and stretch mark, or only certain types? Yeah, so on adrenal.com and under the blog section, we have a few articles about weight gain and adrenal tumors. And this is important both because the cause of the weight gain, but also how it relates to surgery and whether the patient needs to lose weight before surgery. So the classic stretch marks and the weight gain is from cortisol producing tumors. That's the most classic, that patient develops stretch marks and weight gain from Cushing's syndrome, cortisol producing adrenal tumors. Certainly not all patients do, and patients with Cushing's syndrome come in all shapes, and certainly some are slender and some are not, so they come in all shapes. But classically, it's due to the high cortisol. But certainly you can have weight gain from aldosterone-producing tumors. Classically, pheochromocytomas do not cause weight gain. In fact, in older textbooks, it was actually this dogma that was taught to medical students and medical endocrinologists that you will never see a patient with a pheochromocytoma who's obese, and that's just not correct. Pheochromocytoma patients come in all shapes and forms as well. The thinking was because the high catecholamines cause this hyper overdrive of your body with a high heart rate, high blood pressure, and high metabolic activity, and those patients just couldn't get obese, and that's just not the case. So those patients come in all shapes and forms. But typically, stretch marks and weight gain primarily comes from cortisol-producing tumors, but sometimes from aldosterone-producing tumors as well. All right, so this is another question about the heart and the effect of adrenal tumors on the heart. I had bilateral tumors. I ended up needing 2 heart ablations because my ventricular tachycardia was so bad. Do you think the tachycardia was because of Cushing's? So ventricular tachycardia is another arrhythmia similar to atrial fibrillation and can sometimes be treated with heart ablations. And I think I answered that yes, the cortisol-producing tumor, the Cushing syndrome, can contribute to that, and often the cardiologist will have to get control of that arrhythmia, and then once either the cortisol-producing tumor or the aldosterone-producing tumor or the pheochromocytoma is removed, your propensity to develop heart arrhythmias will go down. Obviously, you can have heart arrhythmias from other reasons that are not related from adrenal tumors, but we certainly know that adrenal tumors is a major risk factor for developing those problems. All right, there's a lot of great questions. So here's another one related to your heart. So this is a pretty straightforward question. Is a stress test from a cardiologist required prior to surgery? So is a stress test required from the cardiologist before surgery? No, it's not required. So it all depends on the individual patient. So if you're completely healthy, otherwise you don't have any previous symptoms from chest pain on exertion or angina or previous heart operations or stent procedures or cardiac procedures, otherwise you don't need a stress test. But if you do have a cardiologist, it's probably a reason that you do have a cardiologist, so it's always important to keep the cardiologist in the loop that you can have surgeries. That's not true only for adrenal surgery, but that's true for all surgery. Our team will work together with a cardiologist, and in many cases we already have all the documentation that we need. And it's not really so much about the surgery in of itself, it's information for the anesthesia, for the anesthesiologist to be able to provide that service in a safe manner. So it's quite rare, frankly, that people have to have a stress test just for the adrenal surgery. But it's all individual, and it depends on your history, what kind of symptoms you have, and whether and when was the last time you saw a cardiologist. So, but if you're otherwise healthy, you haven't had any major symptoms or problems from your heart, you don't need automatically to have a stress test. So next question is, I had a right adrenalectomy in 1997 due to Cushing syndrome, and now I have two adenomas on the other side, on the left side. Do you advise that I do another adrenalectomy? Also, is it possible that my adenomas are too big for the mini backscope adrenalectomy and will require going through the belly? Okay, so a number of important points here. So the patient has the right adrenal gland has already been removed, and now there's tumors on the left side. So again, we'll go back to the basics. So just because you have adrenal tumors doesn't necessarily mean you have surgery. It depends if they're overproducing tumors. But let's assume, since this patient had Cushing syndrome, that now the Cushing syndrome has come back on the other side. Yes, then surgery is the only curative treatment. Fortunately, we're one of the few centers in the world that have a lot of experience with what's called partial or cortex sparing adrenalectomy, meaning we can remove the tumors, but at the same time preserve enough normal adrenal tissue. That's what's called partial adrenalectomy or cortex sparing adrenalectomy. So, and that's possible in almost all patients. We do a very detailed scan the morning of the operation to see exactly where the important remnant of normal tissue is located, as well as all the important vessels, but that's almost always possible. When it comes to the size for the mini backscope adrenalectomy, it depends a little bit what the tumor is and if we're worried about adrenal cancer and so forth. But in our hands, we perform the mini backscope adrenalectomy in greater than 98% of the cases. So only if the tumor is very big, say 10, 12, 14 centimeters, or there's concern about adrenal cancer, will we need to go through the belly. So again, I would have to look at all the information, but the overwhelming likelihood is that the partial adrenalectomy is possible and the mini backscope adrenalectomy is possible. This is another question that brings up the importance of partial adrenalectomy. So the question is, I am a 32-year-old female. I found out I had bilateral pheochromocytomas when I was 25 years old. I had the left adrenalectomy in 2017. My right pheo was not bothering me for years, but now my levels are getting higher. I'm afraid to have my other gland removed. How do I know if I qualify for a partial adrenalectomy? All right, this some very important points here. So, first of all, about 10 to 20% of all patients with pheochromocytomas have bilateral tumors, meaning they occurs on both on the left side and the right side. And until proven otherwise, this is part of a tumor susceptibility syndrome, meaning the patient has a genetic predisposition to develop this tumor. So this is very important. So there's a lot of information we're lacking here, meaning we need to figure out, does the patient has a familial disease that predisposes her for pheochromocytoma? So the most common ones are MEN2, multiple endocrine neoplasia type 2, neurofibromatosis type 1, von Hippel-Lindau's disease, but there's been as many as 13 genes that have shown that if you have mutations in one of those genes, render you susceptible to developing bilateral pheochromocytoma. So we need to figure that out. Number one, has the patient had genetic testing? What did the genetic testing show? But until proven otherwise, this patient has a genetic syndrome that makes her develop pheochromocytomas on both sides. She already had the, she had the left side removed, and now she has a right pheochromocytoma, presumably on the right side, and her numbers are getting higher. Yes, almost all patients in this scenario are great candidates for a partial adrenalectomy. Again, the goal here is to get rid of the tumor that's overproducing all those high adrenaline type hormones, the catecholamines, the methanephrines, and at the same time preserve adrenal tissue. Again, you need about 30 to 50% of one normal gland. And just because the pheochromocytoma wasn't bothering her, meaning she doesn't have symptoms, doesn't mean the pheochromocytoma is not causing really bad effects on her body. Again, too much adrenaline hormones is very toxic for your body. It affects the inner lining of all the blood vessels. So over time, it puts you at great risk of not only high blood pressure, but of strokes and heart attacks and kidney failure and so forth. So just because you don't have any symptoms of pheochromocytoma doesn't mean that it's not causing problems in your body. So if the catecholamines are high, as it seems in this case, and she has a pheochromocytoma on the other side, it's definitely the right thing to offer surgery. Also, the other point I want to make is you don't want to wait too long to operate, because the bigger the pheochromocytoma grows, it sort of replaces the normal adrenal cortex. So the bigger the pheochromocytoma is, the less normal adrenal cortex tissue you have to work with. So so it's certainly not something you want to wait too long to have a partial resection, because it'll literally be too little normal adrenal cortex left behind that we can preserve. So again, very likely that this patient will be best served by a partial adrenalectomy. Partial adrenalectomy is best done through the mini back scope adrenalectomy, going through the back. It's much better visualization of the normal tissue as opposed to going through the belly. You guys already know that going through the belly, the laparoscopic or robotic adrenalectomy is very much inferior operation compared to the mini back scope adrenalectomy, but especially for partial adrenalectomies, and especially in the setting of pheochromocytoma, where it's so critical to remove all the tumor, but at the same time preserve the perfect amount of cortex, you definitely want to have the mini back scope adrenalectomy. Oh, and just to clarify that, how do I know if I qualify? So again, the morning of the operation, I do a very detailed protocol CT scan that gives me very detailed information about all the anatomical variations, all the important vessels surrounding the adrenal gland, but also about the remnant. So I can exactly plan exactly what cells I leave behind that are normal and exactly what cells needs to be removed by the surgery. So this question ties into this one. How often do pheochromocytomas occur bilaterally? So I said about 10 to 20% over a lifetime are genetic and bilateral. And again, an important point, if you have bilateral pheochromocytoma, that's a genetic syndrome until proven otherwise. So we strongly recommend genetic testing, because that will be helpful for you as a patient. If you have one of those 13 genes that I mentioned before, almost all of those are inherited in an autosomal dominant pattern, meaning that if you have it, your siblings are at 50% of having it, and your offspring, meaning your children, are at a 50% risk of having it. So they can have surgery performed even before they develop symptoms and before they have a risk of heart attacks and strokes and all those bad things that we don't want to happen to any of us that we hold dearly. So I'm a big proponent of getting genetic testing, because we can tailor the treatment for pheochromocytomas very well and operate at the perfect time and set you up for a lifelong health. Okay, next question is, my grandfather and brother had pituitary tumors. I have Conn's syndrome and multiple thyroid nodules. Is there a correlation between these issues? Should I obtain genetic testing to let my children and grandchildren know if there is a possibility for them to have endocrine issues? Yeah, so this ties in to the previous question about genetic syndrome. So when it comes to so there's a few different variants of what we call multiple endocrine neoplasia type 1 and type 2A and type 2B. You can go on my website and read up on some of these genetic variants, and we've done a lot of research over the years and have a lot of experience with patients like this. Um, in general, pituitary tumors goes with MN1, whereas Conn syndrome can also occasionally occur in MN1, but most adrenal tumors in the setting of MN1 are non-functional. And benign thyroid nodules don't really go together with Conn syndrome or pituitary tumors. So in this particular case, it is a little bit peculiar that you have two individuals, a grandfather and brother with a pituitary tumor and a patient with an adrenal Conn's syndrome. But it doesn't have the classical pattern of either MN1 or MN2. Because of just the variants that are together. So again, just to rehash that, MN1 is pituitary tumors, endocrine pancreatic tumors, and parathyroid tumors, meaning you will have high calcium, whereas MN2, pheochromocytomas, medullary thyroid cancer, and hyperparathyroidism. So in this particular case, I think the risk of it being multiple endocrine neoplasia type 1 or 2 or any of the other familial endocrinopathies is pretty low. It's never a bad idea to go and see a genetic counselor and get genetic testing if you're concerned about it. If anything, it can bring some clarity within the family. Whereas if you said, I have medullary thyroid cancer and my brother has a pheochromocytoma and so forth, then I would say, yeah, definitely you need to have genetic testing. In your particular case, it's more optional. Okay, so last question I have written here, and we're getting a few written in, so we'll get to them in a second. But the last pre-written question is, any advice for patients suffering from adrenal issues, but local doctors fail to take seriously? I called your center, but they said I need to have a CT scan or proof of tumor, and I'm sure how to get this without doctor's cooperation. Yes, so for most primary care physicians, and frankly for many endocrinologists, they don't see a ton of adrenal tumors on a regular basis. And the advice I do give to patients is to direct them to our website, adrenal.com, because it does have a lot of good information there. But certainly if you do have symptoms where you're concerned about a functional adrenal tumor, getting that testing done by the meaning the lab test done by your doctor is number one. If those testings show that there's concern or you're worried that you have a tumor, it's not unreasonable to ask to have a scan performed. Certainly if the lab testing or your symptoms is consistent with, for instance, Cushing syndrome or Conn's syndrome. The reason we our practice is a surgical practice. We wish we could provide medical endocrinology expertise for all patients, but we're surgeons, and if the patients that have symptoms consistent with endocrine diseases but no tumor on a CT scan are best served by the medical endocrinologist. There's an exception to that rule, though, that if you do have primary hyperaldosteronism and the scan shows no tumor because the tumor is too small to be picked up on a CT scan or an MRI, definitely do let us know when we can set you up with adrenal vein sampling in that capacity. All right, so we're getting a few questions in. This question is from the UK, from England, or from Great Britain. I'm from the UK and am getting the runaround with the healthcare system here. Can I come see you without a doctor referral, and what do you require to take me on as a patient? I have Cushing's syndrome. Yeah, so you don't need to be a referral. The best way to become our patient is to go on adrenal.com and click the Become a Patient symbol. We want to see all your labs that you've had so far, as well as imaging, meaning a CT scan or MRI of your adrenal gland, and we'd be more than happy to provide that. So we provide a remote consultation, and we do that for about 60 to 70% of our patients like to do remote consultation. About 30 to 40% that are local to Florida come in and see us here in regular clinics. So we provide consultations to patients throughout the world on a regular basis. So we have a mechanism. But the way to get the ball rolling is to go on adrenal.com, sign up to become a patient. Then one of our adrenal intake coordinators will contact you either over phone or by email to request all the information, and then we'll review that. But we routinely review information from Europe and Asia and Africa and Australia and South America and so forth. So our team is very, very much used to working with international patients. So the last question, is there any correlation between a high stress lifestyle and developing an adrenal tumor? Yeah, that's a great question. In sort of colloquial language and how people think of it, well, it must, I'm stressing my adrenals out, or people know that the adrenal glands are related to stress, and of course they are, because they both cortisol and adrenaline are stress response hormones. What's never been proven, and frankly that would be a slightly difficult study to set up, is whether certain personality types or certain lifestyles or even certain jobs are associated with developing tumor. But so far there's been no scientific evidence that a more high stress environment predisposes you to developing tumors. What we do know from genetic studies on this is that what happens is that you have a genetic mutation in a gene that controls the growth of one of the adrenal cells, and it just starts growing. And why you develop one of those mutations in the first place is really completely random. So adrenal tumor is a little bit unusual, that there's no environmental factors such as smoking or obesity or anything else that's really shown as a significant risk of developing this tumor. So the short answer is not that we know that your lifestyle is related to your risk of developing tumors. All right, so I think we're gonna close there, and thank you again for participating. It's been great, and thank you so much for sending in all the great, excellent questions. Have a great day.